It is now my pleasure to introduce our next presentation, the Professional Issues Panel. During select sessions at the conference this year, attendees can submit questions for the speakers via Twitter, which will be asked by a moderator during the Q&A portion. This is again one of those sessions. If you think of a question at any point during this session, submit it on Twitter using hashtag NSGC17. We will do our best to answer as many Twitter questions and questions at the mic as time allows. For this session, please use the 4-digit attendance verification code 6885, also shown on the screen at this time. Our presenters today for our Professional Issues panel include John Richardson, Stephanie Cohen, and Katie Stoll. John Richardson has 20 years of experience in the public policy arena and has served as the NSGC lobbyist for the last 8 years. Working with many volunteer leaders, he has led licensure efforts developing unique strategies for each state. John has done considerable work engaging health plans focused on coverage, reimbursement, and credentialing policies. He is also working on Medicare recognition for genetic counselors on Capitol Hill. Stephanie Cohen is a board-certified licensed genetic counselor at St. Vincent Hospital in Indianapolis, Indiana, practicing as a cancer genetic counselor. Stephanie has been working to improve access to cancer genetic services by implementing a collaborative process with genetic counselor extenders throughout the St. Vincent Health Network across the state of Indiana. Katie Stoll is the Director of Clinical Services at the independent nonprofit organization Genetic Support Foundation and is focused on developing resources and programs to improve access to genetic counseling services. She has a diversity of clinical experience in the areas of prenatal, cancer, adult, and pediatric genetics, and in a variety of settings, including military healthcare systems, health maintenance organizations, community hospitals, outpatient clinics, and research. I'm very excited that John will share with you an update on our advocacy efforts in NSGC, including some very late-breaking news about our federal bill. And I'm also very, very grateful to Stephanie and Katie for sharing their experiences with us. These are two genetic counselors that I have a lot of admiration for, as they've been able to take threats and turn them into opportunities for themselves. And I'm really, really anxious to hear what they have to say. John? And I think we'll have Katie and Stephanie come up as well and take a seat. Thank you.
Good morning. Thank you, Mary. So I'm going to, as Mary said, give an advocacy update focused on state licensure and our federal effort to get Medicare recognition for genetic counselors. I have no conflict of interest to disclose. So for state licensure this year, Kentucky has enacted a law which makes them the 23rd state. So any Kentuckians here, congratulations. A lot of hard work went into that. It took them about 2 years, so not too long, but a lot of hard work. So thank you for those counselors in Kentucky. This is the current status of licensure. We have 23 states that have enacted laws. Of those, 21 states will be issuing licenses as of January 1st. Minnesota will be actually licensing on January 1st, so they'll be the 21st state that are actually issuing the licenses, so that's great. The yellow states on the map are states that are in progress. Some more down the road than others, but making really steady, significant progress towards getting all 50 states licensed. The key kind of barrier to licensure nowadays seems to be anti-regulatory sentiment. We have a strong argument to overcome that. And in fact, I'd point out in Georgia, they have a sunrise process that you need to kind of overcome to get to the state legislature. That process has never, in the last 10 years, actually approved the profession to go to the legislature for licensure. And they're supposed to have 3 public meetings to review their application. And after the first meeting, they were approved. So hats off to Georgia. I think they're on their way to having success, which is a great accomplishment. In terms of our federal effort, we've taken a very deliberative, disciplined approach because we wanted to do things the right way, which sometimes takes more time up front, but can really pay dividends in the long run. So we've worked with the Ways and Means Subcommittee on Health, worked with their staff to iron out a piece of legislation that the committee is more than likely can really get behind. And then we have been working steadily for the last 2 years with Representative Eric Paulson. Mr. Paulson represents the 3rd Congressional District in Minnesota. He's been working hard with us to kind of perfect this legislation. And he is going to be introducing this bill in the coming weeks, and he's very excited about doing that. And so rather than me kind of talk about that, I thought I'd have him. So Congressman Paulson will give us a little talk via video.
Thank you, John, and good morning to all of you there in Columbus. As you all well know, healthcare reform has been a major focus in Washington over the last several months, and I remain optimistic that Congress will act to improve healthcare delivery across the nation. I believe that a central tenet of health reform should be paying for quality, not quantity. Medicare modernization is essential. The current system does not pay our providers based on how healthy they keep their patients, but reimburses them according to how many tests and procedures they order. There is a better way. Tying payment to results will help yield better healthcare outcomes. That's why I am so excited to be working with genetic counselors like yourselves to modernize Medicare by improving access to your important services. When properly utilized, genetic and genomic services can save lives and open up a new era in healthcare delivery. Today, practitioners often struggle to keep up with the pace of technology as new tests explode into the marketplace. It's an exciting time for healthcare to be sure, but as you know, this can also create an environment that can lead to wasted resources and poor quality of care. Evidence shows that genetic testing doesn't always make sense for every patient, and unnecessary tests contribute to rising costs and distrust of what can be life-changing technology. And that's where you come in. Genetic counselors are a critical part of the solution. We need to ensure these technologies are used appropriately to ensure high-quality care while avoiding wasteful spending. The lack of recognition under the Medicare program for your profession creates access barriers to your services, and not just for Medicare beneficiaries. Hospital credentialing and coverage by other payers can suffer as well. Why would Medicare cover the services you are uniquely qualified to provide, but not allow you to be paid to provide them? It just doesn't make sense. So I'm really excited to announce that in the coming weeks, I will be introducing legislation that would recognize genetic counselors as practitioners under the Medicare program. This is one important step towards modernizing Medicare for our seniors and disabled citizens. Improved access to your services will increase the quality of genetic services and decrease costs. In order to be successful, I'll need your help. Please be on the lookout for more information from NSGC on how you can get involved and convince your member of Congress to support the effort by becoming a co-sponsor of this important bill. I want to thank the National Society of Genetic Counselors for this opportunity to provide an update on our activities, and I look forward to working with all of you to enact this legislation into law.
So it is pretty exciting stuff. Mr. Paulson is a great member of Congress. He's on the subcommittee of jurisdiction. We're probably going to have a really great Democratic member who's going to introduce the bill with him, which we're really excited about. And he's on the subcommittee. I can't announce his name today, but hopefully in the next week or so, I'll be announcing who that is. But so the next step will be to gain as much support as we can within the House of Representatives. And so that's where you really are going to play a pivotal role. And so we'll need to build up as much support in the form of co-sponsors as we possibly can. I and my staff will be providing you with action alerts, which will make it very, very easy for you to become an advocate. Luckily, a lot of you have been involved in state licensure efforts in the past, and I've been amazed through those efforts at how natural advocacy comes to you all. It's just part of your skill set, I think. So I feel good about generating that support fairly rapidly. These action alerts will, again, contain everything you'll need to become an effective voice for the genetic counselor profession. We'll, draft emails that you can send to the staffer. We'll actually list to you, give you the email of the staffer. All you need to do is kind of personalize the message and send it on. So be on the lookout for that in probably a few weeks. At first, we will be kind of tactical in who we want to bring onto the bill because we want it to be as bipartisan as possible. We don't want it weighted one way or the other, heavily Republican or Democrat, so hopefully we'll have a good bipartisan bill. In terms of the prospects, obviously if you've been paying attention, there's a lot of uncertainty in D.C. today. It changes, by the minute, it seems. So a lot is uncertain. However, I can tell you that there will be a health care bill later in the year, probably December. It won't be affordable care type stuff. It'll be stuff that they have to get done every year. There's a Medicare extender bill. There's some other things that are probably going to be rolled up into a big omnibus package. And if we can demonstrate that, as the congressman said, that you actually do save money for Medicare, the odds are fairly high that we would get into that legislative vehicle. If the Congressional Budget Office doesn't see it like how we see it and the congressman sees it, then the effort's going to take a little bit more time. But the Congressional Budget Office will be definitely pivotal in our near-term success. So I'm hopeful that will happen. And again, we'll be coming back to you for you to weigh in and help get us to the goal line. Thank you very much.
Well, good to see so many people out this morning. I want to thank NSGC for inviting me to speak with you all today. This is quite a wonderful opportunity to speak about a topic that's near and dear to my heart. I am an employee of Genetic Support Foundation, as Mary indicated, and I mention this because some of the resources that we've developed through Genetic Support Foundation are things I'll be talking about today. So as I'm going to be speaking about prenatal testing and the need for creativity and advocacy for us as genetic counselors in the world of prenatal genetics. This is becoming pretty complicated for us. I think that there's been concerns with how women have been counseled about prenatal testing options for decades, but I think this is becoming increasingly complicated as the tests that are available to women in pregnancy now are becoming increasingly numerous and complicated. There have been calls from some that all women should be receiving genetic counseling pre-test now, where when we started in genetic counseling, very few women were really offered prenatal genetic testing. Now all women are. So the question comes up, should all women be offered counseling to be really supporting informed autonomous decisions about these tests? But certainly with 4 million births per year in the US and only about 2,500 clinically practicing genetic counselors, that's a pretty rough equation. We're really not able to meet one-on-one with every patient in the way that we have in the past. So what I'd like to talk to you about today is how we can be creative about really meeting this need at a time when there's more people that need our services than we can provide on a one-on-one basis. But before I talk about the future and where we're at now, let me talk a little bit about the past and where our roots are as genetic counselors. So as you all are aware, our profession was really formed at an important time in American history. So the first genetic counseling training program at Sarah Lawrence College was established in 1969. That coincided with women's reproductive rights movements. And another guiding principle for our profession was really a rejection of eugenics ideology and practice. So out of this, these bioethical principles of autonomy and really protecting patients' informed decisions around reproductive genetics emerged and really became kind of the foundation of our work as genetic counselors in the early days. But now we have genetics really in every area of healthcare. The need for our services is growing all the time in many different areas. And as that happens, we're really trying to grapple with how to meet this need given our current workforce. So how do we make sure that we're able to expand our access? And with this, there's been a lot of pressure to say we can just follow up with genetic counseling on the back end after testing's done. And I think that this makes sense in many areas of genetics, that that model might work. But I really want to encourage us all to remember the reason why this pre-test counseling was really so important with regards to reproductive genetics and prenatal genetics. And I think that we should really, it's really imperative of all of us, no matter what our role is in the realm of prenatal genetics, to really do our part to try to ensure that patients are given that opportunity to make autonomous, informed decisions about testing free of coercion. And again, we can't do that on a one-on-one basis. So how do we find creative ways to be advocates for our patients? I don't think that we need to be barriers to access. I think that we can creatively figure out ways to address this need in a way that's maybe different than how we started. So I'll talk about some different opportunities that we found through these challenges, some really great work that a lot of genetic counselors are doing in this space. I'll talk a little bit about alternative service delivery models. Also, the work that many genetic counselors are doing to really take the lead in developing resources, educational tools, and decisional aids. And also, I think that probably the most important thing we can do is really supporting and educating our non-genetics colleagues to do a better job of providing this pre-test genetic counseling. So I first became aware of the issue, or I became most aware of the issue of routinization of prenatal testing a couple of years out into my professional life as a genetic counselor when I became pregnant with my first baby. And the counseling that I received was basically the medical assistant handing me a completed test request form and instructing me to go to the lab for my 16-week blood draw. This really opened my eyes to how this testing was being handled in the prenatal setting, and I took a look at what was happening in our institution. At the time, I worked at a military hospital, a training hospital, and we had obstetricians, midwives, family medicine docs, residents, all offering prenatal testing. And what we found when we looked at ordering practices for prenatal screening is that some providers ordered it on 100% of their patients, and some providers ordered it on none of their patients. And I wasn't sure what the mark was for informed decision making, but I was pretty sure it wasn't 0%, and I was pretty sure it wasn't 100%. So we really wanted to look at how we could improve that. So my colleague Dana Knutson and I embarked on this group appointment. So we had a kind of a contained system, and we were able to really offer all women who presented in pregnancy this option to come and to a group visit with a genetic counselor, either Dana or I led. And we did this for a few years and saw over 5,000 women through this program. We also were able to demonstrate increased patient knowledge and also decreased uptake of prenatal screening tests, which to us indicated more active decision making on the part of the patients. There have been a lot of us in this room that have probably been involved in some way in group visits. I know they're not new, but it's exciting to see that this is still happening. I found just a recently accepted article in Prenatal Diagnosis this month out of Canada that also, looking at group appointments, found that similar to individual counseling, they could decrease anxiety, increase perceived personal control, decrease decisional conflict, and actually were more successful in increasing patient knowledge than one-on-one counseling. Other groups are doing this as well. The Mayo Clinic has the study now that's been looking at group appointments. They too have found increased knowledge, decreased decisional conflict. They have found that some patients have concerns about privacy, though, which indicates that a group visit's not going to be the one and only answer that's going to work for people in pregnancy. So that brings us to this idea of online decision aids, other tools that could be used outside of that group context or one-on-one context. A study by Miriam Kupperman and colleagues at the University of California, San Francisco, published a few years ago in JAMA, found that implementation of an online decision aid offered to all women in their study did increase patient knowledge, also decreased decisional conflict, and decreased uptake of prenatal testing, similar to what we saw with our group appointment. Unfortunately, this decision aid actually didn't make it into clinical use outside of the research study, but there have been many new tools that have been developed since, including one that I've been fortunate to be involved with the development of. The Genetics Port Foundation was able to work with the Washington State Department of Health to create a series of educational videos for patients. There are 7 videos in the series. It really models a lot of what we talked about in the group appointment at the hospital I worked at so long ago. But we have audience tested these videos extensively. Many people here were involved in helping review and help us script these. They've been reviewed by patient advocates, parents of children with disabilities, healthcare providers in different specialties, and they're available freely online in both Spanish and English now. There are studies ongoing looking at using these videos in practice as well, and so far preliminary reports show that they are also increasing patient knowledge and decreasing decisional conflict with regards to choices about prenatal testing. So this is paraphrased from a meeting we had with an advisory group at Genetics Port Foundation about talking about access issues and how we were going to address the growing need for genetic services. And one of the physicians that I work with said, you know, the best way to handle this is really to work to increase the knowledge and competency of the primary care providers. If you can lift the primary care providers up, you're going to lift up our whole community. And that really resonated with me, and I've really tried to look for more opportunities to do that. And I found that I really find that if I can have an hour with a group of doctors to talk about these issues, that's going to be more impactful than the hour that I could spend one-on-one with a patient, because hopefully all those providers are going to take some of the lessons that they've learned and really transfer that to the patients and do a better job than what I received as prenatal counseling. I'd like to just recognize some of the work that's been done by many genetic counselors to really work towards educating the primary OB providers, especially the work from the prenatal SIG here at NSGC. In the last few years, leadership under Blair Stevens, Shannon Waylock, Melissa Hsu, and Corey Feist, many resources have been developed in terms of patient educational materials, provider educational materials. We took a role in the positive predictive value calculator that's online and well used. And we were invited through NSGC to participate in a collaborative webinar with ACOG and Society of Maternal Fetal Medicine that went out to many primary OB providers and is still available for the ACOG membership online. I think these types of collaborations are really important. This actually resource list is something that I copied and pasted directly from the ACOG website. These are still all listed as resources for their members, and they're all NSGC developed tools, which is pretty incredible. Other important decision aids and tools. So the Perinatal Quality Foundation has created this genetic education module, which is a subscription service that provides both continuing medical education for providers and their staff, and also decision aid tools for patients. I know genetic counselors, including Renee Chard and Erica Sturm, were involved in the creative development of these tools and resources, and they are a great thing to check out. The Jackson Laboratory, a nonprofit research institution, has developed a whole series of educational modules for providers. Emily Edelman has been involved in that work, and there are really great resources to direct primary care providers to learn more about these issues and to do a better job with patient care. Last, I'll just put a mention to a collaborative project between the Mayo Clinic, the American Society of Human Genetics, and Kaiser to develop an online educational module for providers about prenatal cell-free DNA screening. Again, multiple genetic counselors involved in this process, including Karen Hansen and Kimberly Barr, to create a really great resource for primary care education. In closing, I just wanted to share a little bit about some of the kind of how this might all come together. So part of the reason I've been involved in lots of different areas of genetic counseling is because I live in a fairly small community, Olympia, Washington, south of Seattle, and the capital of the state, but still pretty small. And I've been the only genetic counselor in a pretty large area for a while, so I've had opportunities to do lots of different things. The Olympia Obstetrics and Gynecology practice is a private practice, the large OB group in my hometown, and where I got the pretty pitiful pre-test counseling 11 years ago. And since that time, I've really been able to establish great relationships with all of the providers in this practice, and I'm regularly invited to come give updates about ACOG guidelines and prenatal genetic tests. They feature our videos on their home website, and they encourage all patients to watch them before meeting with their doctor for the first time. We've developed a little decision aid tool for patients to give their preferences about what they'd like to do for prenatal testing so that they have something to facilitate that discussion with their provider. And we've directed them to resources that we've created on our GSF website to help keep current with guidelines and other tools. So this has been a wonderful partnership, and I bring it up just to say that if you live in a small town, you can make a big difference even if you're not part of a bigger institution. But I'd also like to share the experience of the Swedish healthcare system up in Seattle, which has really taken this on a much bigger scale. Nancy Palmer there has led the charge in really becoming the liaison to all of the OB community. And in this healthcare system, they have about 200 OB providers, about 10,000 births per year. And over the last year, she has been working with her colleagues there to develop a whole suite of resources, including educational videos, printed paper brochures. They've got all of their genetic testing information on an app called the Circle app by Swedish that has information about all the prenatal testing and links to their videos. And they've really become a trusted resource among the primary OB providers in this community, and I think it's really been a great thing for their group professionally. I think also the Swedish healthcare system has really appreciated and sees what a difference this is making in terms of better efficient use of the provider's time, more standardization among the practice of their OBs, which decreases their liability. I mean, everybody sees this as a win-win situation. So just to summarize, I'd just like to encourage us all to be creative, be flexible, to think about how we can take the lead in terms of developing tools and resources to really work to expand our role in protecting patient autonomy and supporting that in the prenatal area. And most importantly, I'd really like to encourage you to continue to develop relationships with the providers that you work at in whatever community you're in, because I think it's those kinds of grassroots efforts that are really going to help us make the biggest difference now. So thank you very much.
Good morning. Thank you to Mary and the board for asking me to talk today, and I'm really excited to share some of the work that our group has been doing on service delivery and thinking about how we can partner with our non-genetics healthcare providers. All right. And I want to present this in the context of not just service delivery, but in access, but also in job satisfaction and how, maybe implementing new and creative ways of providing service can really push us and allow us to expand our own professional development. So one financial disclosure, I have been a consultant for TRM Oncology. So just to let you know, we'll be talking about this collaborative model that we have worked on throughout the St. Vincent Health System, describe some opportunities to improve efficiency as part of this model, and then how implementing this has really allowed for some satisfaction within our own career development paths. And I probably don't need to speak to this group about the need for cancer risk assessment. I work in a cancer genetics department. There are 3 genetic counselors now within our department. We work in a large hospital, but we are part of a larger hospital system. And the need for these for genetic counseling has really increased over the years as we have more evidence-based knowledge on what we should do with this information. There's a lot more demand for these kinds of tests, but the access to our formal services is somewhat limited, especially if we look at geography. And some states probably have more issues with this than others, but it certainly is not unique to our area. And then in terms of the time and resources that it takes, we do have to see how we can best utilize our time and work to the top of our license and profession. So our hospital system is spread out pretty widely. Our hospital in Indianapolis is the largest within our system, but there are 14 hospitals, and we are the only cancer genetic counselors within our hospital system, and there are many other hospitals that don't have easy access. They would have to drive to see us, or even in other hospital systems, there's somewhat limited access to genetic counselors. We are part of a larger hospital network system, Ascension Health, which has hospitals in 21 states and Washington, D.C. And when we tried to find other cancer genetic counselors, even within our own health system, we were really only about 10 or 12 of us for all of this whole hospital network. So in thinking about service delivery and how we approach the process of providing this service to individuals, we decided to take a triage approach to referral, providing services in person, and now telegenetics has evolved, and focusing really on that testing practice, the practice setting, and then physically where we're seeing these patients. A lot of innovation, I think, comes out of necessity, and I think that one thing that happened to us was one of our hospitals, a sort of a mid-sized hospital, was seeking accreditation by the COC, the Commission on Cancer. And they approached us and asked if they could list us as one of the sites that they referred to. And while I was happy to do that, I also knew that in the past 10 years, I'd received a phone call about once a year, maybe once every other year, from a nurse that was ordering some genetic testing because she had questions and she knew that I was there. And I was happy to help answer her questions, and we just didn't see patients from that region. If they were referred, they didn't show. Even though it's only an hour away, it's a more rural community, people didn't want to drive into the big city. So instead of saying no, or instead of saying, yes, sure, you can put my name on your list, what we said was, how can we work together? How can we help you improve your process? And so we tried to approach this from the standpoint that they were doing this anyway, and we wanted to help them do it better. So we implemented a process of reviewing surveys, family history, and really looking at this from a triage standpoint. What was something that was pretty straightforward that we were going to be able to just know we're going to order testing? And again, this is a few years ago, so the time before panels, when we say, yeah, they meet criteria for BRCA 1 and 2, versus they have a more complex history and they might need different testing. So we sort of went with this triage model and directed people toward our genetic counselor extender that was in the offsite local community for the straightforward cases, and those more complicated cases would still be seen by the certified genetic counselors. And when we initially set up this process, we were doing an outreach clinic. We would actually drive to these locations. So in the process of setting up this collaborative model, which is what we like to call it because we're really collaborating with our non-genetics healthcare providers, and our first collaboration was with a nurse practitioner who worked in our high-risk breast clinic, and that really, we learned a lot from that process. And our extenders now are located within these communities, and many of them are actually nurse navigators, and I'll talk a little bit more about the education process that we use. But training those extenders so that they have some knowledge base, and this has been an evolution as well. A lot of one-on-one work went into this, a lot of observation, just trying to provide them with resources. We do set boundaries, clearly identify what each professional will be working on. We have a family history survey tool that allows us to do that triage, and we provide ongoing support. This is a relationship. This is not a rescue kind of method of referral. We are with them every step of the way. And then we implemented a case review, so every month we can all talk together virtually and review these cases online. So each discipline really brings a unique strength to the table, and we really wanted to try to capitalize on the strength of each of these healthcare providers. So of course, genetic counselors have the expertise in genetics, patient education, psychosocial support. I think one other really important thing we bring is the family context. So many providers that do genetic testing never mention that they should send their relatives for genetic counseling or genetic testing. And I think that's a unique perspective that we have that we hopefully would not lose. And experience in how these conditions impact, psychosocially the whole family as well. The extenders are typically these nurse navigators that are embedded with oncology centers, so they have the education already in oncology. They are already familiar with patient education, psychosocial support. They are on site. They're right there, easy access. They provide local ongoing care. One of our extenders works in an infusion center, and so she sees these patients throughout their entire treatment process. They're also familiar with the local resources. So if I'm seeing someone that lives in another community an hour away, I may not know all of those other providers that they need a referral to. The physician partner is primary caregiver. It may be an oncologist. We have a radiologist that's really involved in one of our sites. They're available for writing orders, managing the follow-up care, and they have those relationships with the local specialists that those individuals will need to follow with. So we did a pilot project with St. Vincent Anderson, a hospital about an hour away. They're a mid-sized hospital, about 200 beds, and they have a very active mammography suite because they provide service for an even larger catchment area. We put a paper questionnaire in the mammography suite as well as in the cancer center. And we reviewed about 12,000 surveys over the 2 years, representing about 9,000 unique patients. It didn't actually take that long. It was less than an hour a week of us to look through these surveys. We had a triage criteria that we used. We identified about 8% of people who probably would meet criteria for hereditary breast ovarian cancer, some kind of a risk factor there. About 4% seemed to have a more complex family history that we felt like if they wanted more risk assessment, it would need to be done with us. And about 85% of people didn't really trigger any flags. We've sent letters to these individuals, and about 15% of them contacted the genetic counselor extender. We put their phone number on it, which was really lovely because, again, that was a person that they might have been familiar with. And out of that, 23 appointments were completed with the extender and 52 appointments with the genetic counselor who was traveling there. The appointments with the extender, we really expected these numbers to be flipped. We thought we would be seeing more patients, the extender would be seeing more patients than we would, but we had some turnover in staff. Our extender left, we had to train another person, and so that really limited our ability to have more numbers there. And we also set it up that if the patient had a negative result but a really strong family history and we thought additional testing needed to be done, we would see them after that. So sometimes we did see patients after the extender saw them. So they would do the front line. The amount of time that we spent with those patients was about half of the time that we would spend with a patient that we were seeing up front, because a lot of the work had already been done and we could really focus on psychosocial issues, on the counseling piece, as well as the more definitive risk assessment, because we had some of that information. And we saw all positives in follow-up as well. So we saw 75 patients over those 2 years. In addition, we had 30 direct referrals. So these doctors realized, oh, you're on site, and they started referring to us. So if we looked back at the data from the nurse that had been doing testing over the past 9 years, and she had reached about 14 patients per year, some of which were not appropriate according to the test recs that we reviewed. And we were able to see about 4 times that in the 2 years. So some of the challenges are certainly staff stability. We had some turnover, and that really impacted our ability to see patients with the extender, as well as the steep learning curve. This one-on-one education and doing this, especially with turnover, was an issue. Though we had strong support from the Cancer Center because they were trying to get accreditation, we learned that hospital administrators higher up needed to be aware of this process as well. At one point, we were asked to go talk to the ethics board because I don't know what they thought we were doing, but genetics, very scary stuff. So we learned early on with our next site that before we would actually implement such a process, we wanted everyone on board. And then currently referring providers was another surprise to us. So within our hospital system, some of our providers actually travel to these other sites. And one of our oncologists that refers to us was very upset that these extenders would be involved in the process. And so we really had to do some, although we had done some education, we had to really meet with him one-on-one to explain what we were doing. This has been a rewarding process. I feel like we've really expanded our reach and provided some services to patients that were not going to travel to see us. And I feel that they are getting a better service by having this safety net of our involvement at some level rather than the nurse that was just ordering testing on her own without educational materials, support, and so on. Patients have been very satisfied. They've been very pleased that they don't have to travel. We've developed a lot of new relationships with providers as well as administration. We've become more visible, not only within our St. Vincent Health, but also within our broader Ascension. And really just the whole profession of genetic counseling, I feel, has within our system been raised up. And our roles have really been expanded, and we've really been stretched to do some new things. I think all of these things that I have listed here we do on some level, but being a mentor to our extenders has been very rewarding. We've been negotiating contracts so that we do get paid for this service. Project management and research opportunities. So all of those things have really promoted our satisfaction in our own profession. And of course, like anything, this process has evolved, and it continues to evolve as we figure out what works and what doesn't work. We have now tried to use technology and leverage that to improve our efficiency and the workings of our model, and we now have some automated systems for reviewing family histories that were being collected within the mammography unit anyway. We have electronic family history collection so that now I can look at a 3-generation pedigree for that triage process. I'm not just relying on a quick paper questionnaire. We have a web-based training that we've been developing and is now available on a platform within our St. Vincent Health system, and we're trying to get that to the point where it'll be available throughout the Ascension Health system. It has CNEs attached to it. It's a 7-part series. If we have turnover, we don't have to spend all of that time educating those individuals. We now have those, including a video of a genetic counseling session, a mock session. And we've implemented telemedicine so that we don't have to travel to these sites now. We can actually do them virtually from our own seat at our own desk, and we can fit these patients in anytime, not just once a month. And we've negotiated a contract. So when we did our pilot study, we tracked our time, and we really spent about 5 to 6 hours a month when we were supporting our collaborators. And so we negotiated that we would get a flat rate for up to 6 hours of work, and beyond that we charge per hour, and then we charge for the time that we see the patient. So we are getting reimbursed for this. We now have 3 sites that are operational, and this has been, again, an evolution, and we hope that we might be able to increase the number of sites that we have extenders, but it takes a lot of work to get these set up. This mammogram software, I just thought I'd show a few screenshots. The family history that's collected anyway, it does estimate the likelihood, and we have triggers and flags. The flag that gets thrown up alerts the radiologist that they need to put a macro into the mammography letter, or the report that goes back to the primary care physician. So we've seen an increase in the referrals of our unaffected patients. And then the patient also gets a letter that says, you may have an increased risk, and if you're interested in further risk assessment, please call this number. It's a 1-800 number, and depending on where the individual had their mammogram, they'd be directed to the extender at that site. Our webinar took us a while to put together, but we really think that it's very strong in terms of the educational piece for our collaborators. We have a number of different units. Each unit is sort of directed to something else, so they can go back and review it. We have a pre-questionnaire. We have questions at the end to test knowledge, and we're very happy with how this has turned out. So, just in review, our workflow we've been working on as well, and this is an evolving process. And I think that one of our next steps is, instead of, some of our sites, their physicians were only offering BRCA. They still are only offering BRCA testing. And so in the era of panels, which is what we usually will offer, we're slowly introducing that concept right now as a reflexive test. So the genetic counselor extender only does that BRCA testing. If it's negative, the patient is offered the opportunity to meet with us via Telogenetics. Those post-genetic counselor extender visits anecdotally last about 20 minutes. And then we can reflex the testing and meet with them again if necessary. So far, we've been able to reach this year to the end of August about 64 patients through our process here. With the genetic counselors via Telogenetics. We just stopped driving to 2 of our locations in June. That was our last time of traveling. So we've had 1 telegenetic session in two of these new locations since that time. And our extenders are pretty active in Evansville. They're very motivated. One of them is actually thinking about going back to school to become a genetic counselor, which I think is really cool. And then some of them are just getting started, and in one place we have had a turnover again, so we're looking to fill that. We are doing a pilot project with our partners from Ascension Health in Wisconsin, and we're doing a 3-arm trial looking at knowledge, anxiety, and satisfaction. One arm will be in-person genetic counseling, so our usual care. One arm will be telegenetics, and one arm will be our genetic counselor extender. And we really want to look at these measures and see if these are working as well as we like to think that they're working. So I encourage you to think outside the box. There are many different ways to increase access to genetic services, and what works for your center is going to be different depending on the resources that you have. I think it's important to think about quality and maintaining that. Utilizing local resources is really been rewarding for us and our patients. We put our patients first. We try to meet them where they are. And I think that this has really allowed us to maximize our unique skill set. We're working to the top of our license, and it's new opportunities for us. So I would like to leave you just with this. I would personally rather be driving the bus than hanging onto the back, or even worse, chasing after the bus. So I think that this is happening all around us. Let's take control and decide where we want this bus to go. I'd like to... Thank you. I need to thank my dream team. Without Dawn Nixon, none of this would have happened. She's been my support and sounding board and partner in crime in all of this efforts. And our newest member, Claire Harwood, is equally outstanding and awesome. Our huge team of extenders in all of our different sites, as well as our partners with Ascension, Wisconsin, Amy Stoddard and Victoria Anderson. So thanks to all of them as well.
All right, we have time for questions, and I'll start with a Twitter question. John, given uncertainty in D.C., what specifically makes you confident that this is a good time for our bill's intro? I'm sure you were expecting that one.
I mean, there's never the perfect time, and there's never really an awful time. You got to build some support up. I think that there are unique politics around adding providers to Medicare, sensitivities to other already recognized providers. So you got to work through those issues, which we've done a fairly good job of doing to get those either on board or neutral. Right now, I think it's a good time just because of, a lot of the focus early in the year was the Affordable Care Act, repeal, replace. That obviously failed. So they will be looking to do something later in the year. They're going to have to do something on a couple different legislative vehicles that are healthcare. Like I said, the Medicare extenders, CHIP, the Children's Health Insurance Program, needs to be reauthorized. So those two things alone will have to get done. And it's just going to be a matter of whether CBO scores us as a cost saver or a coster. So like I said, if we're a cost saver, then it'll be much easier than if not. So there's never a perfect time. This is a good time because there'll be opportunity in the next few months. If we miss that opportunity, then we'll have another whole year to build support, and hopefully the following year they have to do the same bills over again, these Medicare extender bills, and we'd have an opportunity at that point.
Bonnie Beatty, Salt Lake City. John, I was wondering, when we were working on licensure in Utah, it was very helpful to try to get patient support for that bill and also provider organizations. Will that be the same for the federal legislation?
Yeah, well, that's a good question. We have some good support already from patient advocacy groups. Certainly, depending on how quickly we can generate that grassroots support, we may be trying to get more patients involved in writing letters and being more active that way through these patient advocacy groups. The other provider organizations, it varies to kind of where they are. SMFM has always been very, very supportive, and it's kind of ironic because their patients aren't necessarily significantly affected by this. But they know what Medicare recognition can mean for reimbursement and other issues. Other groups, have been a little bit more hesitant, but we're still working with them. And those groups have told us that they'll at least be neutral, which is a great thing, because we don't really want to get into a political turf battles with some of these other practitioners.
Hi, Francesca Tavito from New York City. My question's for Stephanie. So after patients were screened and you reviewed the family histories and they were assessed to be general population risk, who informed them that they were at general population risk? And for the few that I'm sure were still nervous and estimated their risk to be higher than general population, were they still offered a consultation to understand why they didn't need genetic testing?
So we actually did not send out any letters to patients that were not high risk. So we did not contact them in either way. We did have a few patients that contacted us that had not received a letter and were the worried well, and we did have a couple of sessions from those inquiries. But we did not inform them that they were at general population risk. We only send letters to the high risk.
So when they filled out the survey were at the clinic that they were at, it said that they were filling out a survey to be assessed, and then I guess the worried well reached out to you.
Right, and now we do it electronically. The mammogram population is interesting. For years, they've been collecting this information, asking family history, and it went into a black hole. Nothing happened to it. So what we've really done is that process has not changed. These questions are identical to what they were, but we just turned on these electronic models, and we actually use that information. So they're not told that they're being assessed. It's just the same process that they've been doing for years.
I find it interesting to be talking about licensure and telemedicine in the same session. At Einstein Philadelphia, our clinic was interested in expanding towards telemedicine. And one of the barriers that concerns us is the need to be licensed in every state where the person is who's receiving the service, not the state where the person who's providing the service. So my one question is whether the licensure helps us in telemedicine, or am I permitted to go ahead and do telemedicine now in any state that does not yet have the licensure? And it'll become that expensive that it'll become only available to those companies that specialize in remote services instead of a regular clinic like us who just wants to reach out to a family member.
Yeah, that's a challenge. And, you know, other providers have had to deal with this ever since the advent of telemedicine. So, again, it's not unique to genetic counselors or genetic counseling. I think that in the physician world, they're trying to address some of these issues through a licensure compact. It has had some success. What it does is that it cuts down on the application process. You still need to process an application, though. Their applications are far, more lengthy than what a genetic counselor would have to fill out. So there is some kind of administrative benefit there. There is also a fee that's still involved. So the compact is really focused on speeding up the process versus eliminating that process or eliminating the fees. That's one model we've thought about looking at. The problem is that states don't want to give up their jurisdiction, and so licensure is there to protect their citizens. They don't want another state to do that job. And plus, that state, if you're New York State, for instance, and if they had licensure, they can't reach into Florida to take action against a provider that isn't providing high-quality care. So it's an issue. It's not a perfect situation, obviously. It does impact your ability to deliver services, but one of your questions mentioned about delivering services into a state where there's not licensure. And so you just need to be licensed in your state if you're delivering services into a state without licensure. The rule of thumb is you need to be licensed in your state if it's available, and you need to be licensed in the state where the patient is if it's available.
We have time for one more question, and I'm going to take a Twitter question for Katie. How do you connect with reluctant OBs who resist the opportunity to become educated? You're welcome.
Well, I would say that many OBs are reluctant, but I think that maybe just persistence and humility. I don't know. I think that I haven't met a lot of obstacles, actually. Even in going into small communities where we've started to implement telemedicine services, I've been greeted pretty warmly by OBs who are really looking for a resource. So I'm sure that there are some difficult ones out there, and maybe they're not where we need to spend our energy. I think that there are plenty of OBs that are really, really receptive and really welcoming of this support, and I'd say focus there.